members in our chapter that have a little more experience than you. Some people are practicing singularly. I don't want to remove I know plenty of people where I work that are lone rangers in their hospitals doing the things. And I get calls from them on a constant basis. So what do I do with this or what do I do with that? So I'm hoping that the Partners in Practice program can make sure that not just the newer folks that are joining the society, but folks that have been in practice can get some inspiration and maybe some tools that they can use to improve the practice that they have in their facilities. Who knows? When you have a poster, I know that's the only way I got to go to conference. And if you have a compelling enough case series or practice change that you've put into motion in your facility, um, if you're able to change minds and bring a good outcome to your folks that you're taking care of in the woundostomy continence realm, this is where you can go to maybe start that and perhaps make a difference in the folks that we're taking care of. So I'm glad you all are here.
And now we'll go to Carol Bauer, who's been nice enough to present her topic on taking your idea to poster, to abstract to poster.
Yeah, idea to abstract to poster.
Perfect. Well, thank you very much. And as far as my background goes, I am currently where everyone wants to be. I am currently retired after many years of practice. But when Maureen asked me to do this, I said, well, all right, I'll do that. I was the last abstract chair, and I was a chair for 4 years. So I have a lot of experience with posters and abstracts, reviewing, and really to know what the reviewers are looking for. And maybe I like to think of myself as a really good cheerleader for WOC nursing and for getting younger people interested in presenting and pulling themselves up a level. So I'm going to try. I told you guys earlier, I'm a Google Meet novice. So I'm going to try sharing my screen, and I'm going to pull up some slides. Hopefully. Oh, wait, up here, share entire screen. Let's see, we're going to go here, share my screen anyway. Show my screen. I'm trying. Let's try this. Here we go. You can see it, right? So okay, great. My topic is transforming ideas, project to abstract to poster. Mostly tonight, I'm going to talk about project to abstract, because once you get to the abstract point, really developing your poster is a lot easier. And I think what people really struggle with is project to abstract. So probably the question I hear most often from other WOC nurses is my project really good enough? And my answer to you is yes, it's absolutely good enough. And you should really think about, I want to do my project. I want to put my project forward. Now, I do have to say, Maureen said, if you have a compelling case series, I personally have never written a case series poster abstract. I have only done practice innovation. So that really is where my experience is, but I have read a lot of case series. So I hopefully can answer any questions you might have. But again, is my project good enough? The answer to that is yes. Any project that you've been working on is good enough as long as you follow the directions. So here are some samples of past abstract titles from 2024 and 2025, where I thought maybe could give you an idea of how easy it is to take your idea and really put it into practice. So if you're looking at case series, we all have had complicated abdomens. And hopefully we're all taking pictures of all those complicated abdomens. So where to stomacite the complicated abdomen was one poster abstract that got accepted. And they had a series of abdomens that they showed, and they applied the guidelines. So that was kind of a cool one. Now, I think probably the only thing that marks you down in something like that is maybe it wasn't such a novel idea. But if you hit all the other criterion, you're still going to pass and get a passing score that will probably meet the cut point. Another one was vascular access team, and the WOC nurses meet under pressure at the hub. So this was a team that was working with their vascular access team to look at pressure injury underneath the hub of IV sites. So that's another thing that maybe you're working on, something like that, where you found a problem in your facility that you wanted to move forward with, and maybe you just had, a little group and you met together and you drafted some guidelines. That's a great poster to bring forward. Maybe you were going to do it as a case study. They wrote it as a case series where they had at least 3 cases they were showing. But you know what? I could also see that being a practice innovation. Another one was use of negative pressure wound therapy with novel integrated peel and place dressings in 4 patients with acute wounds. I guess if you thought enough about it and it was a new item that has come forth in practice, you could write that up. So then some practice innovation, enhancing nurse knowledge regarding incontinence to prevent hospital-acquired pressure injuries. How many of us have done in-services where you've done maybe pre and post testing, and then you had an innovation where maybe you developed posters and put them around the units, or you brought in new products? Those are all really good practice innovations that could be written into a poster. Another one, development of a virtual inpatient WOC nurse program, expanding care access and working at the top of your scope. So see, there's another thing that you could do. Or here's just a really simple one, a turn team implementation guide. So there's all kinds of things. If you've written a patient handout, I know maybe in today's world we aren't writing our own handouts as much, but maybe you incorporated a pre-written handout and it improved patient outcomes, or that would be something that would be good under a practice innovation too. Now, I like the KISS thought. Your idea does not have to be complicated. You just have to follow the directions. I would say the majority of abstracts that get rejected or score below the cut point is because they didn't follow directions. They either were submitted in the wrong category, or they don't have all the components that are required for whatever category they have submitted to. So here are some common errors, and we were talking about this before the start of the call. Number 1, waiting until the last minute. Don't wait until the last minute. The submission site closes November 1. So right now is a perfect time to put your thinking cap on and come up with your idea and choose where you want it to go. So don't wait till the last minute, because you're going to need to really write it out in like a gajillion words and then cut it down to the required 300. And that really takes time, and you need somebody who's going to help you. Another common error, which I've already talked about, is not following the directions. We've also had posters or abstracts submitted for work that is not completed. So let's say you're developing a turning team, and you say, and we're going to implement our turning team in December. Well, then you got to wait till next year. So the work has to be completed. This will not get you rejected, is use of trade names instead of generic terms, but you will have to go back and fix all of that. That is not allowed. No trade names, no company taglines, no company logos. And then we used to try and help you if you submitted your abstract to the wrong category. And I would contact you and tell you, hey, we're moving your abstract because you put it in the wrong category. But we began having so many people doing that is now a reason that you would be rejected. So you really got to read the instructions and figure out where should I be at. Other common errors, failure to get permission, such as patient consents, compliance approval or IRB approval. We had one gal submit her poster. I think she got accepted. She submitted her abstract, got accepted. We were even to the point of poster development, and she lost her job over this. She did not have approval from her organization, and we had to, as a society, pull all the work from our online platform. So be sure, if you need permissions to do this based on your institution, that you obtain them. Last year, when we were reviewing posters, we had posters submitted that didn't match the abstracts. So you got to make sure, and then of course that's going to be pulled down. When we go through and actually do poster reviews, we do compare it to your abstract. Another thing that we see happen a bunch is submitting an abstract without all of the authors' names included. So this is why you need to do it well in advance, because you're doing it at the last minute. You think, okay, I got Sally and John and Peter and Margaret, and you forgot to add Betty. So, but you go, oh shoot, I'll just put their name on the poster. No, it's not going to fly. So you would have to then just put an acknowledgement at the bottom of your poster. But it is a common error. It won't cause you to be rejected, but you might have hurt feelings within your work group. Other things that will not cause you to be rejected, but are big no-nos, is the incorrect use of the terms such as WOCN rather than the WOC nurse. I think that has really gotten to be less often that I was seeing that. So just remember, WOCN is a trademark of the society, and you are not a WOCN, you are a WOC nurse. So how do you find out how your abstract will be scored? So as we know, 2026 is going to be in Indianapolis. Good location for us Mideast region people. You'll go over to the website WOC Next. I think it comes up just WOCnext.org. You can do the / abstracts and click on event information, and then click on abstracts here. You'll see here these different categories come up. There's important deadlines. There are abstract author resources. So if you don't feel like you got enough out of what I'm telling you, there are some bite-sized learning. There's some blog posts. I can't remember everything. I think there is, shoot, what do we call that when they talk? I can't remember where Jody does. Anyway, that's up there. There are written instructions for abstract submission. There's the review process, and you get down here to abstract scoring. This is where it's going to tell you what you need to have as part of your abstract. So when we look at the required elements, if we look at the case series, there are 5 sections that are required, and you must include a minimum of 3 cases. If you don't have 3 cases, you will be rejected. The 5 categories are the statement of your clinical problem or challenge. So why the heck are you doing your abstract? What is the significance of your problem to practice, including the past management? If it doesn't really pertain to WOC nursing, and yes, we've had posters that have been submitted that don't really pertain to WOC nursing, then that'll be scored low. Your solution and clinical treatment approach. What did you do that was so exciting that you want everybody to know? The outcomes, and then your conclusion. And remember, your conclusion should not be for a case series. This should be adopted for everyone. So maybe the conclusion is going to be, this worked well for us in these situations, and more research needs to be done to investigate this as a possible standard of care. Those would be the kind of things you'd be looking for in your conclusion. So the required abstract text elements for a practice innovation. Now this one's only 4. Maybe that's why I like practice innovation. I don't know. I'm just saying. Of course, you want your topic and why it's significant to practice. The purpose of the innovation or your objective, and why did you do this? And then what was your process? How can the reviewer figure out basically how to replicate what you did, and then what were your outcomes. And we don't want steps 1 through 20 in your abstract. That's what would belong on your poster. What we're looking for is just a general gist of what is it that you did, so that the reviewer actually has an idea. I'm not going to go over a lot for research, because generally people who are doing true research know these things, but you need to have topic, purpose, aims, or your research question, your study design or your method, your results, and your conclusion. If what you're developing for your abstract is your DNP project, which is a QI project, then it needs to go under the practice innovation and not under the research. Research is really true research, not a quality improvement project. So tips for writing your abstract. Maybe a little repetitive, but again, the reviewers don't know your work, so you want to explain it clearly and succinctly. I always started my abstracts out by writing them in not thinking about the word count, and then going back and trying to figure out what could I cut out without losing the meat of what I was writing. If your topic is more informational and descriptive, then you may not be appropriate for an abstract, and maybe you want to write it as a journal or newsletter article or a blog post. But really, if it's about a project you've been doing, it probably is something that you can write into an abstract. So results or outcomes are used to evaluate your abstract, and it again should reflect completed work. If it's not completed prior to the abstract submission, then you're going to have to wait. Again, case study requires at least 3 cases, but it could include more. I've seen some that have 8 or 10 even that they discuss. Maybe you can't have that many pictures or discussion points on your poster itself because you're limited in size, but at least 3, but it could include more, not less. If you have less, you will automatically be rejected. Tips for writing abstracts. Again, we went over this a little bit. No names. Names don't belong in the abstract. It could be justification for rejecting of the abstract. The last time we were doing them last year, that was not. We did have you go back and fix it. And some suggested descriptions would be a small rural hospital in the Midwest, academic hospital located in the southwestern United States, things like that. You don't want the name of your hospital there. That, of course, can go on your poster, and you don't want your name or any patient names or anything like that anywhere within your abstract. That's not where they belong. Sorry, I got to take a drink. No PHI is to appear in the abstract. I know I had one gal, she did a poster and gave her patients all names. I had to reach out to her and ask her, are these their real names? And she said, no, these are my made up names for them. I said, oh, okay, then it was all right. So make sure you have no PHI included. So some tips. Have somebody review your abstract prior to submission. I can't tell you how important that is. My husband will read mine. He's not a nurse. He's an engineer. But, if I'm thinking in my head that it makes sense, and he'll review it and say, this doesn't make any sense. So that's an important thing. I would also have a colleague read it to see, does this seem clear? What do you think I could cut out? What do you think I should add? And remember to be concise. It should be an overview of your work, and it should generate interest to want to learn more. So your abstract should make somebody, when they're looking at it in the online format, they should say, oh, I want to go and see that poster. So if you're attending in person, or even if you're attending virtually, you might be going through reading abstracts and marking, I want to go and read this one, or I want to go and take a picture of that one. So that's really what you want your abstract to be able to do, is to draw interest into your work. Again, the abstract word limit is 300 words. It does not include your title, your author's names, or your references. But if you are doing a practice innovation and you write the word topic, which is what I would do, the word topic does count in your 300 words. So it's important to think about that as you're doing it, that those, you maybe have 5 or 6 words that are going to be included in each of your categories. And again, don't wait until the last minute. That's probably the biggest thing. Don't wait. So required references, each abstract must include at least 1, but no more than 3 references. And the references must be cited in the AMA format. If you're unsure, there are lots of online resources. I know I like to use the Purdue OWL. I found that one to be helpful, but these are 3 others that Donna Bliss, who is now the abstract chair, has suggested that she has found to be helpful. And I know you can't click on my links here, but these links are available to you in that author resources tab at the website. So you would be able to go ahead and look these up and make sure that you have it and are following the AMA format. Again, you need at least 1, but no more than 3 references. Sometimes we have people submit like 10 or 20 references. It's kind of unbelievable. I never had that many. So anyway, you can have more references on your poster itself if you think you need it. That's certainly your prerogative. But for the abstract, at least 1, but no more than 3. Again, another one of those didn't follow direction things that we see happen over time. So some general information. If you're submitting an abstract, anticipate it's going to be accepted and be able to make arrangements for conference registration early. You should know the 1st of January. That's one of the dates, I think, around that time, whether you've been accepted or not. I'm pretty sure it's January. That's one of those important dates. It seems like it used to be around January, whether or not you were going to be accepted, but certainly look up that date. The primary author will be expected to register for the conference upon notification of acceptance of the abstract. And you generally only have 30 days after notification to register. So be prepared to do so. And registration means that your full conference fee is paid. Now you can attend both in person or virtual, but this just does serve as confirmation of your attendance and your ability to present your poster. So either way, virtual or in person. You know, every year we have somebody have something that happens, and they want to change primary authors. We usually let that happen. Some family emergency, whatever. You know, we're all nurses. We all live in that world. Usually national office will be able to help you. Juliana is very good at being helpful for whatever needs to happen. If we change primary authors, if you want to change from in-person to virtual, usually there's, or vice versa. Those are things that usually can happen. Don't tell her I told you that. So general information, specific instructions on posters, including how to cite references, acknowledge your agency, all that kind of stuff will be sent to you if your abstract is accepted for poster presentation. All the abstracts will be made as e-posters, and then you will, if you're accepted, and then you have a choice of choosing whether you want to have an in-person on, traditional poster, or if you want to just do an e-poster. My personal preference is I think having done it both ways is I kind of liked having my poster up in the poster hall. And now you can print your poster on fabric, which is kind of cool. If makes it easier for transport. If you were thinking that you want to do an oral presentation, as a general rule, or the oral presentations, I think usually we have like 5 that are in the poster abstract general session. They are generally research based. If we don't have a lot of research based, then we look for the QI projects. But if it is given, then you will, if you have been given an invitation, congratulations. And national office will let you know what you what you need to do for that after that. So maybe we can brainstorm. And I got a few questions here. I'm going to just read them all because then I'm going to stop sharing my screen so I can see you all. What is one project you're working on? I wish I would have wrote these down before. Are you on any committees? Have you had a run of a particular problem? Let's think about those questions. And remember, the WOCN Society has a mentorship program. If you want to mentor somebody who's going to help you, I'm helping somebody right now who has an idea but wasn't exactly sure how to move forward. Send an email to abstracts@wocn.org and you will be signed a mentor to help you. Don't wait till the week before because you're probably going to be told, oh, I'm sorry, you asked too late. I got kind of, when I was abstract chair, I got kind of like mean about that you need to really ask in enough time for you and your mentor to work together. And good luck with your submission. If you have any questions, reach out, ask Donna, ask Juliana, send me an email. I guess I didn't put it on here, but you could always email me. You can find me in the directory. All right, I'm going to go to figuring out how to unshare my screen. Okay. Let's see. I think I closed this. There we go. Stop presenting. I think it'll stop in a minute. Stop presenting. There we go. Okay. Let's have some discussion.
Great.
Does anybody have
awesome. That was awesome, Carol.
Thank
Thanks.
you.
Yeah.
Does anybody have a project they're thinking about that they want to talk about? A committee you're on or anything like that?
Well, I'm thinking about a poster on our discharge process for our ostomy patients. And I don't know about you guys, but I'm tired of having patients show up at the south entrance with nothing but a towel around their abdomen because their DME company failed them. And so I've included a lot of resources in my discharge instructions. I use the UOAA. I use all three, actually four. I use Marlin, Coloplast, Convatec, and Hollister. I sign up my patients for three. I mean, we're talking about, I know it's trade names, but that's what I'm working with, right? So I sign them up for samples with three ostomy companies, and I know that they are all very active with their ostomy patient support rooms. So, but and since we've been doing that, it seems to me I have less patients showing up with towels around their abdomen. I make sure that we send them home with a month's worth of supplies. I know where I used to work, they were saying you can only send them home with 3 pouches. Okay. No, not when you have a novice working at this and they, are it's not enough. So, I'm thinking that might be a poster that we could do as a group where I'm at.
I think that sounds like a great idea, Maureen. And you don't have to put the names. You can just say sign up with a national ostomy sample programs.
Yeah.
You don't have to put their names, and that would be good. And it would be even better if you have some statistics. And I think if you don't have statistics, then maybe looking at it from the perspective of, is there a nursing theory that you could link to it? Maybe I feel like because I don't have
there's so many theories.
Self-care, right?
The person who's able to do it themselves. And before we leave, I mean, we have adopted visiting every day with our ostomy patients, even though we have so many wound care patients to take care of. My focus, because our hospital doesn't give us enough staff, is my ostomy patients, because they are the ones that are going to be living with this.
Yes.
And they're the ones that need to take care of it. And they're the ones that we have the most hope of getting them self-sufficient. So that is where we spend our energy. And so anyway.
Mo, do you guys have a like an outpatient follow-up that you do with your ostomy patients when they're discharged?
You mean like a call?
Like a call, a follow-up with a clinic, like with an ostomy clinic?
Well, I have 4 different ostomy clinics in my particular area. I have one that's campus-based, and I include that person, and I say, this is your real world nurse. So when you're out in the real world, this is the one that if you have problems, you're chugging along and everything works, this is who you're going to call if you need any extra help. She's going to look at what's going on. She's going to look at that, and we have that. But there are also 3 other places in my area. Southeastern Michigan is kind of large, and Royal Oak isn't necessarily easy for people to get to. So I've got one in like 4 corners, that we go to. But I could put an appointment in for them as a thing that they need to do to check in with an ostomy nurse. I could do that.
Yeah, I'm just wondering if that would help, because I know it seems like we do have one of the nurse practitioners. She's tied with the colorectal surgery group, but she sees a lot of the other acute care surgery patients also that have ostomies, and that has helped to have that access to her. And then we have our ileal conduit patients will come back to us, but it really does make a difference. And then the phone calls too. They think they're sitting at home and they're not. I'm always like, call me if you have questions.
Yeah.
You can't remember everything I say, and people don't read the stuff that you put in your the folders for them. So that has helped too, is following up when you just have a patient that is not going to make it at home because they're older and they just have no other family members who are stepping in.
Right.
You just give a call and then oh, you need to come back in. We need to go back over stuff.
So Maureen, Ashley has a suggestion too, to see if you have a nursing quality indicator, maybe potential reduction in readmission, reducing post-op complications. Those would be something measurable if you can get your IT to help you collect that information. Maybe what were your readmission rates for ostomy surgery prior to your starting this intervention to what is it now? And that would be a really good outcome for your abstract if your IT can help you do that. If you have a generalized date.
Right. Well, I've got another program that we've done, and we've had the blessing of a colorectal surgeon who has used our foundation to provide a 36-day electrolyte supplement to our ileostomy patients. And it's always been we're doing it, and every ileostomy gets this 36-day supplementation of electrolyte drink, but we don't have time to follow it up and do it, but the data is there if only we get to it.
Does the physician have the data?
I have the data.
Oh,
I mean,
data.
I have everybody that we gave this supplementation to. The only thing I don't have is the readmission. And he said, oh, we should sick one of the medical students on it, or one of the residents, make this their project. And I have seen nothing. We do have a nurse practitioner in colorectal who's been following it. So maybe I could tag team with her to get that done. But
Well,
so
Mo, it would be a retrospective look. That's the thing, is it would be retrospective. So there could be a tie-in to looking at known patients, and that they received the intervention. And then you could do a simple chart audit to see if you could put a readmission time frame into Cerner, Epic, whatever your EMR is. And if they're flagged as a readmission, you could do a chart audit to see what they were readmitted for.
right.
And even, solidify that data point. I was going to also add to your previous point about discharge and I know that I'm in industry now, but prior to my role with Coloplast, is one of the things that we always did after post-op was we started with the signing everyone up for Coloplast, Convatec, and Hollister discharge programs. And what I found as I don't know what the nursing theory would be, but it was time that my daily calls for addressing patients with, insurance questions, reordering supplies, not necessarily post-operative complications, but my call rate went from like 12 to 15 a day down to like 1. And
Oh,
so
great.
there's some time management in there that because I always have said that, as even again, I'm speaking biasly, but truthfully, but our industry partners in that way, they're an extension of us at home. And so when you think about the far reaches that our patients go where home care is not available, they often will have that extension. And I know that, that's part of that conversation because it allows us to be more available for those complex fistulas and be hopefully not having to meet someone at the door in the ER with a towel around their waist.
Mm-hmm.
Right. Is there a best practice that we could add to our WOCN guidelines in terms of ostomy discharge that's related to phone calls, that's related to signups with industry partners, that's related to um, connections with outpatient nurse practitioners that are ostomy certified? Is that something that we could add to our guidelines? Or our best practice document?
It's possible, I suppose. Maureen, one of the other thoughts that ran through my head as you were talking about your collaboration with the colorectal person is maybe you could even do a practice innovation abstract about the process of doing the collaboration.
Ah,
You know,
absolutely.
that would be another way. If you don't have a bunch of data yet, you could write it on the collaborative part of the project. When I was doing that hernia program, I
Right.
wrote on developing the team. I wrote an abstract on the process of developing the team. So that's something else to maybe think about. Is there something in that line?
You know what, Carol? We started this in 2023.
Oh,
I mean, that's how long.
maybe you'll have some data then.
Yeah, I hope.
Yeah.
People have been reversed since then,
Yeah.
on
Yeah.
our list of people. So there's a lot of cases, of people that we've taken care of. So
Okay, you got a month. Yeah, top to
Start
it.
writing.
Start writing.
yeah,
Gotta
I'll
get
add
people involved. That's why I was suggesting the other part. You got a month.
right. Yeah.
Anybody else have some ideas? A committee you're on, or another project you're working on, a paper you wrote at school?
Oh, Harry, I can tell you another example of something that happened recently, and it has to do with supply chain. Now my hospital is Corewell, my system is Corewell, and there's 200 hospitals inside the state of Michigan. It's now the largest healthcare provider in the state of Michigan. And there are a lot of hospitals on the western side of the state. And there are some products that other smaller places have adopted. There's one product that I'm interested in bringing, and I brought it to my inventory control person, and I'm having a literal battle with my inventory control person because he says it's too expensive and I don't want to bring it in. And it's a product that it's an adhesive remover. So when we have Marcy's, think about all of the dressings that we use with the Metapore tape. Think about the thick butt paste that we use on patients. The adhesive remover does a great job of removing all that. And I tried to get it in, but it's a standoff right now.
So, what about, I mean, you've got barrier wipes, correct?
Yeah.
Okay. Usually the barrier wipe and the adhesive remover go hand in hand with, if you bring one in, whichever one you bring in, you got to bring the adhesive remover. I mean, look at it this way. If you can reduce your Marcy's, but also I'm looking at the negative pressure therapy drape. That stuff works phenomenal. Post-op ostomy patients who that it's really sticking, it's a world. I mean, when we brought our adhesive remover in, we took it to the patients and they picked the one that worked the best. And they were like, this is the one you got to get.
Mm-hmm.
And I mean, we have had, that is like my favorite product.
Mm-hmm.
And then everybody will say, well, you always have access to the best products. I said, it's right in your clean utility room. You need to go get it.
Well, that's the barrier right there. Putting it in a clean utility room, because managers on each unit have to decide what products that they want to pay for their units. And
Here's the deal. I had that issue too when I was down at Good Sam, and Lisa can confess because she said I tried this for twice before and they wouldn't. And I said, I don't take no for an answer. So I got with my manager and we met with the people in logistics. We call them logistics, and it was the manager. And we were like, these are the products we want to bring in. These are the ones we want to take away. By doing this, we can reduce the number of runs that you've got to bring up to the floor. And we're also able to start dressings quicker because we have the products available on the floor. We're not delaying care. We put all this together. We got their buy-in. And then my manager goes, okay, we're going to write this email together. And here's what we're going to say. And she said, okay, if we're going to give them a specific date, and if they don't get back to us by that date, we are moving ahead with this project and we will be replacing. And she goes, that is the best way to get things done because they forget about it and they don't get back to you. And then you can go in and put in all the products you want. Seriously, we did it at Good Sam. It went really well. And we got all the products we wanted, and we took off stuff that we weren't using so that all the nurses had what they needed to do the dressing changes, to have the ostomy supplies that they needed. Not everything, but the ones that were the major ostomy floors. They had the products they needed. They had the rings, large and small. They had adhesive remover. They had irrigation sleeves. When I can't find an irrigation sleeve, I know where to go find one. The top bin in the clean utility room on our what I call the penthouse floor. So yeah, it's like getting their buy-in and then running with it. And she said, this is the best way. They can't complain because you notified them. They did not respond. So that was, if we don't hear back from you, we'll believe that you are for this program. Only respond if you have any negatives to this.
And
so that sounds like that could be an abstract too. You could write is how to get buy-in from, whether you're talking about C-suite or managers, I don't know, however you want to do it, and the process that you would use. That actually sounds like a practice innovation to me, that you would actually be able to write up, and you have your outcome already. The supplies that were needed were available.
Right. And they are, and the barrier is the inventory manager.
Well, I think you got to look at how can you include the inventory manager as part of the team and make them be part of the team and not just be a roadblock.
They really need to understand that this is not about just bringing a product in. This is a product that's going to improve patient outcomes.
Mm-hmm. They have to understand it on a personal level.
Yeah.
So I think that's how you got to sell it, Maureen, is and then that would be a really great abstract to write is however whatever practice improvement you did is, and how did you bring them into the team and sell it to them as a way that they were going to be responsible for improving patient outcomes. Right?
Yeah, that's,
and maybe find out like what it is. I know one time I did in-servicing down in our central supply, not when I was at Corwell, Beaumont, whatever we want to call ourselves. And I went down there thinking that they were going to want to know, like, red went with red and blue went with blue or whatever. And they wanted to know, why does the patient use this? I
Yeah.
was so shocked because my idea of what they wanted was product driven. And once they understood on how it affected a real person, it made a difference.
Mhm.
So maybe that's something you want to think about, the perspective on how you're presenting it too.
Right. Explain. Yeah.
Yeah.
I totally understand because
Yeah.
there's so much Marcy that goes on that's not recorded.
Mhm.
And I know personally patients that I've known that have gotten all of these. If they had just used an adhesive remover on those leads, you
Yeah.
know, for the cardiac leads, they
Yeah.
would have had all the spots on their chest.
Right.
Hey,
So
Mo,
how to make how to make how to bring, I'm trying to think how it was, the title was, how to bring product manager into the team for improved patient care.
There
You
you
know,
go.
or bringing patient care, making patient care a reality to the product team.
Yeah.
Mhm.
For
Something like that
Yep.
would be a great topic for a practice innovation. And lots of people probably need that kind of information
Yeah.
on how to do that, because I'm sure you're not the only person with that kind of a problem. Now, whether you could get that as a completed project for this year, maybe not, but it certainly is something that could be considered for, for 2027.
Yeah.
And it would be a great project.
Yeah.
hey, Mo, does he understand how the product works and what you're going to use it for? Because you could go in and do a little demonstration on him and put some different dressings on him and go make sure you keep a piece of drape from negative pressure and put it on his hairy arm
And
and say,
see how
now
it
this
feels.
is, we're going to take this off without, and this is the one we're going to use with the adhesive remover spray.
Mm-hmm.
And see how easy it is. And now imagine if you were a patient,
Yeah.
how easy and how comfortable that would be versus pulling on that skin.
Ah.
Sometimes they got to feel the difference.
Oh,
I have to say, I purchased that product from a product like that from Amazon to use in my home on my husband. So I do purchase it. You can just buy adhesive remover from Amazon, and I buy it because he gets all these boo-boos, and that's been very helpful. He even called me in today and he said, will you take the hydrocolloid off my leg with some adhesive remover?
Mo, the other thing I was going to add to the conversation is that as we all know that there are brand specific, there are higher end adhesive removers and skin barrier preps. One of the things that does help is to kind of justify, is it a special order item that the team just has to start out with to gather data, and you just order a box. Now the other alternative too is knowing I know your GPO, knowing, like if you are working in the confounds of a less expensive option, there are those in the adhesive remover category that are not necessarily going to be the high end options, but they do the job. And so I find that if you fall into those kind of categories, looking at who provides your Band-Aids, your gauze, your tape, not necessarily like your 3M brand or your, anything from a manufacturer, but more of that umbrella of the basics. If you can slip in something like an adhesive remover in that category, it may come in at a lower cost where there's less argument with
yes.
purchasing, and then you're able to have like that higher end and I'm just going to use this just because I'm just thinking about both Hollister and Coloplast have their adhesive removers and also their skin barrier preps, but most of us are used to using like the 3M Cavalon, those kinds of things that are more expensive. And the alternative is possibly using a Medline adhesive remover to kind of bridge the gap of cost. And it's like, what do you need to do to get the means to the end? And that's also part of that. But I will say what what was recommended for the removals, the sample removaling, it is successful because I had to do that with my doctors, my surgeons that kept putting mastisol on my vax and post-op ostomy patients,
Oh,
where they were getting Marcy's just naturally from swelling post-operatively, let
yep.
alone then removal. And I mean, I was like, if you don't stop doing this, I'm literally going to put mastisol in your chest hair and put back drape on it and give you a wax.
See how you like it.
So,
Mhm.
I mean, there is all of those things as well that if you work with your purchasing, and I will say this just from being in that arena, is you can also find workarounds. And that's where you do exactly what you said here. Like, what's the fallout if you don't have this available?
Mhm.
Is it
Mhm.
measurable? Is there outcomes? Because we know that there's consensus papers out there and literature out there on Marcy's, especially with postoperative surgical patients and ostomy patients.
Yeah,
So
and you're kind of reading my mind, Ashley. That's exactly where I was going with it because, okay, so I've already started working on this a little bit, putting out just some information for the unit managers to understand why it's important to have a adhesive remover on their unit. A lot of nurses, when I show it to them, they're like, "Where have you been all my life?" You know,
mhm.
and so I'm thinking that I'm going to start to work on this lower cost alternative that we already have in house. We already can order it. It's already being, it's already available to us. So there's an education thing that I have to do related
The
to that.
other the other thing to think about too is in these conversations is yes, these are budgeting things, and these are unit cost, but this should be such a low impact to that budget, especially with the lower cost option, that getting buy-in should be the least of your worries to getting nurses to actually use it and what that educational plan looks like. I mean, honestly, it should be pretty straightforward, but I mean, I'm just thinking back. I used to carry around adhesive remover wipes in my pocket like Band-Aids at a pediatric office. So,
Mhm.
I mean, they were just readily available. And honestly, the argument could be that it's all coming out of the same bucket,
Mhm.
regardless of the unit
Mhm.
expenditures. It's coming
Yeah,
out of the same bucket.
that's right. Absolutely. But it's one more thing that he has to put on the shelf, blah, blah, blah.
But it's something that's going to improve patient care and patient outcomes. And that comes back also to your customer, your patient satisfaction scores.
Right,
That all ties in. He's just not seeing the big picture because
right.
he's not experiencing it.
Yeah. And
And
he's,
then, is there anything you can take off the shelf, Maureen? Give and take.
yeah, right.
So
Yeah,
you gotta maybe that'll be the other piece of your puzzle is how to give and take. Because I'm sure you have something on there that is not being all that
huge.
utilized that you could take off that was part of your formulary.
Mm-hmm.
You
Yeah, I'm sure there is.
Simplification.
Yeah, I know. That's the thing that we have to think about.
Well, with purchasing, it's about SKUs. It's not about patient outcomes, really. I mean, they're looking at SKUs and dollars. So if you could drop and get a different SKU, then maybe, drop a SKU and trade a SKU, then maybe that would be helpful.
Yeah.
Another idea.
Yep, I found that in order to get the products that I wanted, I advocated for 4 different pouches. I got them. I can't believe it, but I did. And then those pouches weren't used. And then I advocated, I said, oh, we're just going to swap them out for convexity that I needed in different widths and sizes, et cetera. And it was no big deal. They did it like that.
Right.
So,
So
so
maybe that's where you got to think about it too.
mhm, for
So
sure.
2 different avenues on how to get purchasing on your side.
Yeah. Oh,
And then I guess another, if you do an education piece with your staff on using an adhesive remover, there's a whole nother abstract you can write. Maureen,
and
you just got a whole list,
it's 3. I just
right?
got 3.
You got a whole list.
Jeez.
You got it for
Well,
sure. Gonna
guess
get
guess what? Guess what? I've got 4 new walk nurses that I'm gonna put these on.
perfect.
So
Perfect.
we could get them to go to the conference. And
Exactly.
they're all very eager, and they're great.
Fabulous.
Okay.
Fabulous. Fabulous.
About succession.
That's right.
All
Mhm.
right. Well, gosh, look what time it is. We're almost done. Anybody else have anything great to say? Betsy, what do you think? Your first partners presentation.
I think it's great. I got a whole page of things written down, notes for my next abstract.
Yeah.
Perfect.
Not this year,
Perfect.
because I'm not ready.
Oh, that's all right.
I have
Next
enough
year is
things going on. I
great.
can't do
Yeah,
that
you,
too.
you did one last year, right? So for the last conference. So good
Yeah.
for you.
Yeah. I have a quick question. So my colleague and I are working on unit-based education with our nurses. We have a really big team at our hospital, but we are struggling with patients going overnight leaking, and I'm sure everybody else has the same problem. And we're really struggling with seeing the routine pouch changes that are simple. Like, we want to kind of set those to the bedside nurses so that we can kind of focus more on our complex patients, and then also doing other things, research and things like quality improvement projects and things like that. So we've been doing a lot of unit-based education, going around to all the units, teaching simple pouch changes, how to change pouch at night. You wouldn't leave a patient sitting in their bowel movement overnight. So you shouldn't do it with their stoma. Just try to change it. It doesn't have to be perfect, all these things. And so I was trying to talk her into doing like a poster. She's very interested in doing it. But we're not sure how we're going to measure our success. So, like, the success of our education. We can look at like how many leaky pouches we have, like consults we get a day, but that, it really varies. So if anybody has any ideas on how we could maybe show that our education is working, other than doing like do you feel like you understand more now, you're more comfortable, kind of a questionnaire?
Can you monitor by the number of patients, like when they leak, like when they change their pouch and then they go in, and I don't know what we have Epic, so we can go in and put pouch change, and then if it leaked, they can leak, and then you can say, oh, that one leaked. Okay. Since the education we did, are we having as frequent leakage? And maybe go in and do a little chart review and see of your patients that who have new ostomy pouches. I'm also wondering too, do you guys put your new post-ops in soft convexity post-op? Because we're thinking about doing that because we're having leaking issues. And I know I've started doing it on a lot of my patients, well, because they have the os at 3 o'clock skin level.
Yeah,
And
right.
I think that's, based on the conversations we've had at conference and things that I'm hearing out there too, is that I think that that's becoming more of a standard of care. So that I don't know if the WOCN Society is looking at, is that in our guidelines? Should that be a part of our guidelines as far as like what it would be the criteria around that? I did have a question for you, Betsy, around is the expectation that, I guess I'm going to start with the question is like, what is the level of accountability of the nurses in ostomy care? Are these all new ostomates? Are they even giving it a shot, or do they just have the mindset that, oh, you're a leaking ostomate and therefore we put in a consult. I don't care if it's 3 a.m. Okay.
Yes,
So
we keep it up and then we leave it for you.
yeah. So
They'll be buying.
thus far, have you seen any reduction in your consults?
I don't know that we've seen like a reduction in our consults, because we still want them to consult us so that we can come, because if they're leaking, they might need a refitting. It might, like, we want to take a look.
I was gonna say, do you think that, like, again, these are new, these are just new post-op patients. So again, reassessment is, I guess, if you look at your standard of follow-up on post-operative education, we always try to do like 3 teaches, consistently. And so we were going to see the new ostomate patients no matter what. And so we had that baseline as far as we would follow up with them during the day when we were there no matter what. If they're leaking overnight, I guess what is this is something to think about. What is the threshold for that nurse to change a pouch before they would put in a new consult? So my point in that is that if you are teaching them how to put on an ostomy pouch, and let's say, okay, I'm teaching you how to do this, you've verbally given me back the instructions or the I understand, the outcome would be is, are you seeing additional consults? So again, there's kind of a process improvement, a change in practice, because if you're going to see them anyway, you can follow up and ask, was your pouch changed overnight? How many times was it changed overnight? And maybe that's your measurable, is that if you're seeing the patients anyway, your point of reference would be, what was that nurse capable of doing? And then it also gives you then almost a gap analysis on where you need to continue that education.
What we're seeing now is that nurses are coming to us and saying, or they're sending the consult, and we're seeing that we're still getting the leaky pouch consult from the night before, but they're changing the pouch. And so we're seeing more of that. We're seeing them trying. So I think from what I can tell, like our education is working sometimes. And 'cause it's a huge hospital, so it's hard to hit everybody and get everybody the information. But we are seeing, I feel like we're seeing more people trying because they want to tell us that they're trying, and because we'll give caregiver celebrations. So, they want us to know that they tried. So I am seeing that.
You're at the clinic, aren't you?
Yeah.
Yeah. Okay.
But thank you. That was really helpful.
Sounds like it could be written as an abstract.
Next year.
Right. Okay, next year.
No. Well, Carol, I want to thank you for coming on tonight, because you've always been like, I always hear your voice in my ear. That could be a poster, and all the stuff that we're doing and trying, and that's the thing. Whatever it is that we're working on, it could be. You just have to follow the rules, and there's posters for a reason, and maybe you could even go to conference. You have to kind of beg your facility and your institution, say, look, this is a practice innovation that could help a lot of other people. So you need to help me get to conference. And so as long as you put in the time ahead of time and not do the last minute stuff, I just want you guys to know that there are resources that are available. And I'm sure Donna, as the new chair, would be more than happy to assist you if you've got an idea. And go to your chapter members, and see if there's anybody, this is what I've been seeing. This is what I've been looking at. I just gave you 3 ideas. Jeez, I'm going to be busy. I'm supposed to retire soon. What the heck?
Yeah. I think certainly go to Donna and ask for a mentor.
Yeah.
I know that Barb Piper, she is hysterical, first of all.
Yeah.
And she loves mentoring people.
Mhm.
And she meets you at conference, and she reviews your poster and all kinds of things. So, even if you have a little question, ask for a mentor.
Yeah.
It won't hurt you, especially if you're a lone ranger. Ask for a mentor.
And also remember that the Mideast chapter gives a poster award, and Betsy knows about that, and Brittany, because they won the poster award. So here's another thing is that after you do this work, submit it for the award, because you could be eligible.
Right.
And win not only an award, but there's a monetary award with it also.
Could help to pay for that traditional poster you want to put up.
There you go.
Right. And I would highly recommend getting the material to make your poster, because it travels a lot easier. You can just fold it up and put it in your suitcase.
Yeah.
So, Patty, I have a kind of I don't know what the word is, secretarial kind of question. So we've recorded our event tonight. Will it be on YouTube?
I think we'll go ahead and post this on YouTube. And then if we could also have your slides, Carol, then that will all go together and they
So
can.
where would you like me to send them?
You can send it to me, and I'll get you my email after I quit recording. But yeah, we can. I will get that to you, and then we'll get it out there, and then we can post it on. Brittany can post it on all the social media that it's available, and then that way maybe we can get some new members too. So this is great information, and I know I learned a lot tonight.
Yeah.
I'm like Mo. I'm going into retirement November 14th. Ooh, yes.
Congratulations.
Around the corner.
Congratulations.
Yeah. So I'm excited. I know. I kept thinking I've got projects. I'm staying till the 14th because I have projects I want to finish that I haven't had time because we've been covering somebody on maternity leave. But yeah, I've got projects and I'm like, no, I'll give you 7 weeks to figure out what we're going to do. But I also have projects I want to finish up before I leave. So I can make sure that I have those clean utility rooms intact at North.
Right.
So, but yeah, so I think this has been great. I hope you guys have all gotten something out of it. I know I have. And Carol, thank you so much. Thank you for always being one of our supporters.
Yeah, for sure. All right.
All
You wanna
right,
End the meeting, Patty?
please.
I said, Patty, you want to end the meeting? I think we're done.
Yes, I think we're done. And thank you guys all for attending. And we will post that and be on the lookout on the social media.
All right.
right.
Very good.
Thank you.
Thank you, guys. Love
Okay.
you.
All
Bye.
right.
Bye.
Bye. The meeting has stopped recording.
Okay.